Urgent, topical, timely. Power 98.7. Getting you talking about what matters.
Indeed, and we stay with health-related matters, and a story that is equally concerning. The health minister, Arun Motsoaledi, has revealed that since 2025, since January 2025, that's January this year, 155 children under the age of 5 have died in the South African public health facilities. In other words, in public hospitals and clinics and so forth, with a moderate or severe acute malnutrition being identified as an underlying condition. This emerged in an answer to a written parliamentary question by the Democratic Alliance. DA members of Parliament Michael Clark, or Michelle Clark rather, and Bridget Masango issued a statement yesterday calling for multidisciplinary action to deal with this. I mean, let's get more on it. And I'm joined on the line, my guests on the line this evening are a nutritionist with the National Department of Health, responsible for child nutrition, Zandile Gubega. Good evening, and thank you so much for your time.
Good evening, and thank you for having me.
Thank you so much for joining us. Also, let me welcome on the line Dr. Chantal Witten, who is a child health care advocate. Good evening to you, ma'am, as well, and welcome to the show.
Good evening, TT. Good evening to the listeners as well.
Thank you very much for joining us. Let me start with you, Ms. Zandile Gubega. And just let me just get you to put things into perspective for us. The numbers, obviously, when you hear 155 children dying in public hospitals since the start of the year, that sounds staggering. I think one child dying would be a lot. What are we dealing with here? What has been found, to be happening that has led to the deaths of so many children?
Okay, thank you. Thank you very much for this important question. Within our public health facilities, there are many factors that can contribute to high number of deaths, or maybe rather to say children who find themselves at a high risk of death because of a few key factors. Many of the children who will die, perhaps maybe on arrival within the health facilities, are mostly very complicated cases. Most often cases, we're talking about children who present with what we call comorbid conditions. These are the children who will present with either malnutrition and another condition. And we're referring to children who might be presenting with HIV, children who might be presenting with a TB as well. These are often children who are likely to die. Then in addition, you also have children who might present with diarrhea with severe dehydration, most often due to poor feeding practices, lack of hygiene practices within the environment leading to diarrhea. Some of the children actually present with what we call herbal intoxication. So these are in large numbers children who are likely at the high risk of dying because of several complications, herbal intoxication, and diarrhea with severe dehydration, and this sort of comorbid conditions. So these are not the usual cases. We're talking about children who present with what we call complications. They might present with an edema on both feet. These are the children who are highly complicated. The other key factor that we often find children presenting in hospital is the late presentation, wherein it's a factor that is modifiable from a caregiver perspective, wherein if you delay in seeking care, some of the caregivers, probably because of not knowing what is really wrong with their children, you might find that they are not in the position or are unaware in terms of the malnutrition condition, and hence they present when the child is either complicating because of maybe vomiting or diarrhea, which prompts them to report to the health facilities. Otherwise, you do find children who will be in the home, maybe being treated as an outpatient without complications. But the children who present who are most likely to die in the first maybe early hours of treatment are those children who present with complications. So that is the situation that most clinicians are currently or most likely to face in our hospital institutions. Thank you.
So, okay, so it is not necessarily the case. I mean, when it was said that acute malnutrition, severe or acute, or moderate or severe acute malnutrition, were identified as underlying conditions. Are you saying that is not necessarily? It doesn't reflect the situation in the hospitals necessarily. In other words, that these children did not become malnourished in the hospitals. Is that what you are saying effectively?
Okay, no, thank you for following up so that I can clarify. When we talk about comorbid conditions, it's either a child presents with another condition, be it HIV, and these are the most common ones, a serious condition, TB, and only to find that they also have malnutrition as an underlying disease. They might also be presenting with diarrhea at the same time. So these are the children who we can call them to be complex in light of presenting with this many conditions. So it's not the malnutrition that happens when they're in the hospital. So malnutrition often happens over time. A child will start off maybe not eating well or not growing well to losing weight and then to having moderate acute malnutrition to severe acute malnutrition. So the later severe acute malnutrition, these are the children who will present when they're at that stage where the malnutrition is at its severe form with complications of either diarrhea with a severe dehydration. So that is one of the typical examples.
All right. What would you say then? I mean, can you confidently say, though, that there should not be any cases of malnutrition or malnourished children that are being treated within our hospitals?
It's possible, but it will take a lot of effort. One of the key things that is required that must be done as an early intervention is growth monitoring and promotion. It is possible that we can get to a stage where we are dealing with having to identify children when they start what we call growth faltering or not growing well or losing weight. That is the earliest intervention where we can begin to institute some counseling, find out what are the underlying causes of the growth failure, which could be due to many factors. It could be due to poor dietary, poor breastfeeding, poor complementary feeding, and many other issues such as illnesses in between. Often upper respiratory tract infections, or often issues of vomiting and diarrhea. So it is possible that with good early interventions, we can get to a point where we don't have to see the most severe form of acute malnutrition.
Okay. Let me also bring in Dr. Chantel Whitten, a child health advocate, joining us on the line. Dr. Whitten, what has been your experience then? I mean, the numbers, again, it's very easy to be shocked by the numbers. To say 155 children since January, one child is a lot, as I was saying a moment ago to Ms. Kubega. But I mean, just give us your sense in terms of what your take is, and to hear that it could be that some of these deaths, there were one of the underlying conditions would be malnutrition.
TT, what we see is that firstly, it is high numbers, particularly because South Africa is a middle-income country, particularly because we have a well-developed health system. And so this number needs to be translated, absolute numbers should be translated into a rate for the province, a rate for the district, a rate for the catchment area. And WHO, the World Health Organization, gives us a guideline. It says that as a country, we should not have more than one more than 5 out of 100 children dying. And South Africa is above that 5%. The latest figure says we're around 7.9%. So as a country, we're not doing well. So independent of the number, the absolute number, when you look at the rate for our country, we are not doing well. The other very concerning part of that story is we are reporting the numbers that have presented at the facility and have died in the facility. It does not take into account the number of children that have died outside of the facility. And recent data from a technical group that serves the National Department of Health, it's called the Committee for the Morbidity and Mortality of Children Under 5, also known as COMIC. COMIC has told us that more than 50% of the children are dying outside of the health facility. So in many ways, you could double that number. And what it tells you is that South Africa is failing in protecting children, particularly when it comes to food and nutrition. Now, this does not happen when children start eating. It happens when children are breastfeeding. And the peak age for when children die of severe acute malnutrition is often between 12 and 18 months. And that is the time when we start to move from breastfeeding to complementary feeding, as my colleague from National Department has indicated, is that children over time are losing weight. Children over time are not eating enough, not getting enough food. And of course, there are many factors that are related to what's happening in households. High unemployment, high cost of food, poor caregiving. Many mothers have to leave their children to go and look for work, piece jobs. And these children are not being monitored, not being cared for, and they're falling through the cracks. So we should really be talking about children not thriving, children not growing well, before we talk about SAM. Just to give the listeners an idea of what SAM means. If a 1-year-old should be weighing 10 kilograms, that's the average of a 1-year-old, and that child is below 60% for the body weight, that means that child is weighing 6 kilograms or less. So that's 60%. And that's how severe acute malnutrition is. It's severely underweight or wasted. We do not want our children to get to that level. And while the parliamentarians are debating the numbers, I think what the bigger question is, and the looming question is, are children's food and nutrition protected in South Africa?
And, the malnutrition, is it as a result of, as you say, the manifestations of it will be seen, or maybe let me ask the question in a different form. When do we actually see the manifestations of malnutrition? Is it just purely when in infancy, or are there long-term effects, things such as stunting? And to what extent is it reversible?
So malnutrition is a continuum. So when we look at underweight, then we can start with underweight because children are not weighing enough for their age. We can look at stunting when children are not weighing enough for their height. And then we can also look at the other side of the scale when children are weighing too much. So we know in South Africa, we also have a problem with obesity in childhood. So our latest figures show us that at least for children 0 to 5, 22% are overweight or obese. So that's another problem.
So sorry, doctor. I want to make sure I got that right there. Did you say children between 0 and 5 years, 20%? Is that what was it?
22%.
22% are overweight.
Yes.
Goodness.
So that means more than 1 in 4 children are overweight. And that is again a reflection of the quality of food that children are eating. The food that our children are eating lacks good quality. It's high in calories, so lots of energy. Children get fat because they are eating low quality food, highly processed foods. And again, TT, I cannot emphasize more that we must look at our breastfeeding rates. Because it's the alternative. If you're not breastfeeding, it means that you are formula feeding. And we know that children who are formula feeding have a higher risk, 2 times higher risk of being overweight or obese. So you move from formula to the highly processed porridge in a box, to the 2-minute noodles, and these are the patterns that relate to with what we are now calling malnutrition, but in the overweight, obese state.
Is that to say that formula is not a good thing, to put plainly? Yeah?
Yes. It's not a good thing for 2 reasons. The first one is that as a biological product, breast milk is also protection. It gives your child all the nutrients, all the anti-infective properties that a mother gives, antibodies that go from the mother to the baby. That you cannot get in a tin of formula. Secondly, formula milk is formulated. It is not cow's milk. It has been processed to a point that it is highly processed. It is also loaded with sugar because it tastes nice. So if you taste formula, you taste that it is a sweet product. And therefore, children then develop the taste for sweetness and move from the formula to the cereal box. And this is really, we've seen, and the science shows us that children that consume formula, that consume highly processed foods, will be at a added risk as a predisposition to be obese as children, and then to be pre-obese as adolescents, and then as adults. And they are the future children and adults that are going to have your cardiovascular disease, your diabetes, all the non-communicable diseases that we are talking about now, that we see in South Africa.
Okay. Let me just go back to you, Zandile Kubega, who's nutritionist in the National Department of Health, responsible for child nutrition. One of the important things that Dr. Witten there just mentioned is about a lack of monitoring that is happening. Where are we tracking what is happening with children from when they're born to ensure that they're getting sufficient nutrition, and lest we end up with the crisis where we find them showing up malnourished in our hospitals and so on. What are we doing in as far as monitoring is concerned? What do we have in place?
Okay. What I can say is that growth monitoring and promotion is one of the routine services that are provided across all levels of care. I would say to this effect, children who present within the primary health care level aligns with the immunization schedules and scheduled dates for appointments for coming back to the primary health care for routine services, including growth monitoring. That is one of the platforms where growth monitoring should be happening. But over the years, we've seen that at primary health care level, it's not happening optimally for 2 reasons. One, it's because of children who grow, like when you move closer to 18 months, where they are almost completing most of their major immunization schedules, to find a decline in terms of coming back to the healthcare facilities for growth monitoring and promotion. And to also acknowledge that there are also issues around long queues in our public health facilities, wherein we promote fast queues for infants, young children, and also people who are very sick. So growth monitoring and promotion is a routine service, but we have identified that it's not happening optimally. Number 2 is also the issue of not acting timelessly or fast enough when we identify children who are growth faltering. This has been evident through routine auditing of the Road to Health booklet, where we do find that sufficient interventions are not prioritized early enough to ensure that those children who are not growing or losing weight they get these interventions, be it counseling or be it a measure to ensure that they are supplemented if they are in the complementary feeding period. And then also issues around strengthening breastfeeding support and counseling, and as one of the key interventions to address issues of growth and development in children. So another platform where we do assessment for malnutrition is at hospital level, of which I would say that at that level we're doing much better because all the children who present within the pediatric unit are supposed, it's a requirement that they are screened for acute malnutrition and classification into 3 categories where we classify severe acute malnutrition, moderate acute malnutrition, or no acute malnutrition. The no acute malnutrition children, that is where we are also prompting and pushing that we also need to look at other growth parameters such as underweight for age in order for us to act early.
Okay.
Should I go?
No. Yeah, no, that's fine, Ms. Gubega. Actually, we are running out of time, so I want to just get a quick parting shots as well from you, Dr. Witten. I don't know whether you want to pick up on anything that Zandile Gubega just mentioned, or whether you just want to add something in closing.
Thanks, Titi. I think that what Zandile has shared is the services that are offered and the services that are in place to identify children. But at a broader level, we need to discuss as whole of society, what is South Africa doing to protect children? Because, as I said, we are facing higher rates of unemployment, higher food costs, less care in households as families try to make ends meet by parents working or moving from the rural area to the urban area, and childcare is falling through the gap. As Zandile said, children are measured and monitored at the facilities. So when the children go in for their immunization or they're going into the facilities for, just coming in monthly for weighing, we weigh our children in the primary healthcare facilities. The problem is we are not able to act when the child is growth faltering, when the child is no longer growing well, but the child is losing weight. Often we are waiting until that child is becoming moderate acute malnourished or severely acute malnourished. It's very easy. We have guidelines. We measure our children with a tape on the arm. It's called the mid-upper arm circumference. Your child, when it's green, the child is well, the child is doing very well. When it's orange, the child, you must take care because your child is now losing weight. And when it's red, your child is severely malnourished and has a higher risk of dying. The problem is when our child is orange, what interventions are there to support our children? And the reason why we need to talk about this as a society is because our children are at a risk of not getting enough food in the household. There's lots of discussion about school feeding because there's such high levels of hunger, such high levels of food insecurity. Children need to eat at schools. But we are now talking about our under 5. If they're not in an early childhood development center, they are at home. And at home, the situations are desperate.
Yes, absolutely. Zandile Gubega, is there something you would like to add, just in conclusion?
What I would like to add is that we are moving towards more on preventative strategies. One of the things that we have piloted and we have seen to work is to scale up or extend screening for acute malnutrition at household level. So what Dr. Witten explained now about the use of a mid-upper arm circumference tape, we are trying to scale up that intervention such that mothers and caregivers, family members, are also able to screen their children at household level. It is a pilot project that we implemented in Gauteng and KwaZulu-Natal, and we are hoping to scale up to more districts, working in collaboration with community health care workers.
Thank you so much, ladies. I really, really appreciate your time. Zandile Gubega from the Department of Health, the National Department of Health, nutritionist responsible for child nutrition. I appreciate your time. Dr. Chantel Witten as well, to you too. Thank you so much for your indulgence.
Thank you very much,
Thank you very
PT.
much.
All right. And very ironically, may I add that tomorrow, I guess it's just pure chance or coincidence, we're going to be taking a look at the issue of childhood obesity. Remember, we were talking about exercise amongst adults yesterday. Now we're going to be looking at it from a child's point of view. Child obesity. We'll take a look at it. I mean, the numbers that were shared there by Dr. Witten, scary. 22% of children between the ages of 0 and 5 are overweight in South Africa. 22%. Wow.